Today, we'll discuss the INHALE-WP3 study published in Intensive Care Medicine. Hospital-acquired pneumonia and ventilator-associated pneumonia significantly increase ICU morbidity and mortality. Rapid diagnostics like syndromic PCR promise quicker pathogen identification than standard cultures. The study objective was to evaluate the impact of rapid, ICU-based syndromic PCR on antibiotic stewardship and clinical outcomes compared to standard of care. Multicenter, pragmatic, open-label RCT, which was done in 14 ICUs of the UK. Randomized 554 ICU patients with VAP. After accounting for consent withdrawals and missing data, over 95% had outcomes available. By day 21, follow-up was complete for 185 in the intervention and 189 in the control group. Attrition was mainly due to deaths and transfers. The intervention group had significantly better antibiotic stewardship at 24 hours to 76.5% received appropriate and proportionate antibiotics versus 55.9% in standard care. This benefit persisted at 72 hours. Overall appropriate antibiotic use was also higher in the intervention group. However, use of narrow-spectrum antibiotics was low and not significantly different. Total antibiotic consumption and daily antibiotic use in ICU were slightly lower in the intervention group, but not significantly. At 14 days, clinical cure was lower in the intervention group, 56.7% versus control, 64.5%, failing to meet non-inferiority. Mortality at 28 days was slightly higher in the intervention group, 31.3% versus 28.2%, but not significantly. ICU stay duration, ventilator-free days, and septic shock rates were similar. Antibiotic-associated diarrhea was significantly higher in the intervention arm. Other adverse events, including C. difficile, hypersensitivity, and secondary pneumonia, showed no significant differences. The trial had key limitations. It was open-label, had low adherence to the antibiotic algorithm, and outcomes were influenced by COVID-19. The definition of clinical cure was subjective, and the study was done in a low-resistance setting, limiting generalizability. Despite better stewardship, clinical cure was lower, so this doesn't yet change practice. Further research is needed to ensure rapid PCR truly benefits patients, especially with improved algorithm compliance and better pathogen understanding.